We are back with another subject that is called as pediatrics, and how easily we are going to finish it. You will see it and appreciate. And after pediatrics, we are going to finish the obs and gynae, sir. So let's come back and let's start revising along with me. So number one topic we are going to touch in this is jaundice. So how this jaundice is happening? What this jaundice is? Yellowish color of pigmentation in the body, in the urine and the sclera is jaundice. How this is happening? That we will be talking right now, sir. Now let's talk about the pathophysiology behind this. The fetal hemoglobin is breaking into the heme, then heme is breaking into the biliverdin, biliverdin is breaking into the bilirubin, and this bilirubin is your lipid soluble, which is unconjugated. And yesterday in the pharmacology itself I taught you that unconjugated is not going out from the kidney. So if it is not going out from the kidney, so rest of the areas it will go. So your skin and sclera will be yellow in A choleric or P hepatic jaundice, but your urine will be normal. Why? Because this is unconjugated lipid soluble. So normally what happens, initially it is lipid soluble, it is converted into water soluble via enzyme called as UDP gluconyl transferase. This enzyme will convert lipid soluble into water soluble, and if water soluble one is increasing abnormally, it will come in the urine itself also. So skin, sclera and urine, if they are, that means conjugated bilirubin is increased. If only skin and sclera is involved, that means unconjugated is increased. Unconjugated is increased, my dear friends. So remember right here, the excretion in the urine, because this is water soluble and there is going to be urine and skin, urine, skin and sclera, all are yellow, all are yellow. The pre-hepatic jaundice where lipid soluble is increasing, unconjugated is increasing. Post-hepatic jaundice is where there is a water soluble is increasing, and along with that water soluble, remember this is going to be the post-hepatic jaundice, post-hepatic jaundice. Done. Now normally what happens, if this is abnormal increase, then it will happen. Normally what will happen, this conjugated come outside from the bile duct, secreted in the bile, then intestine, sarcobilin, yellow brown feces responsible. Who is responsible for the yellow brown feces? Your answer is going to be the stercobilin. Now the jaundice is divided into two. One is physiological and another is what's your pathological. Now physiological is like a good guest. Good guest is coming late, going early, and pathological is a bad guest which is coming early and going late. How? If a jaundice is coming after 24 hours of the birth and going within 7 to 14 days, this is going to be the physiological jaundice. And my dear friends, if it is coming before 24 hours and staying for more than 7 to 14 days, this is going to be the pathological jaundice. Daily rise in physiological less than 5, daily rise in the pathological more than 5 mg/%. Total bilirubin 15 mg%, less than 15 mg% in the physiological, more it is your more than 15 in the pathological. The treatment in the physiological is going to be the reassurance, and in the pathological, phototherapy. Phototherapy is going to convert this pathological jaundice into lumirubin, that is going to be the water soluble form, and that is going to get excreted out from the body. That is going to get excreted out from the body. Also you can give the drugs like 𝗵𝗵𝗴𝗿. So physiological and pathological clears. Now how to clinically assess the amount of bilirubin we are having? That is Cramer's rule, my dear friends. Now Cramer rule, if we have to talk about the head massage is given with the help of 5 fingers. So if it is head involvement is there, depigmentation is there, then 5%. Chest, we will do like this. Chest, this is 10%. Abdomen and thigh, it is 12 to 15%. And then palm and sole, this is going to be the 15 to 20%. 15 to 20%. So these are the different values clinically you can evaluate to see the level of bilirubin inside the body. Then coming to the next topic is called as neurology. So jaundice is clear to all of you. So we have talked about the pre-hepatic and post-hepatic jaundice. Then pre-hepatic jaundice was lipid soluble or water soluble? Lipid soluble. Which enzyme was coming to convert it into water soluble? UDP gluconyl transferase. Then it was converted into water soluble. Water soluble form, if it is increased, that is post-hepatic jaundice, and if it is lipid soluble is increased, that is called as pre-hepatic jaundice. That is called as what, sir? Pre-hepatic jaundice. Pre-hepatic jaundice. Done, sir. Now neurology, seizure disorder. What is seizure? Increase in electrical activity in the brain is seizure disorder. And along with the electrical activities, motor activity is also involved, that is called as convulsions. And more than 2 seizures episode is called as epilepsy, and most common epilepsy we will see with the subtle seizure. We will see with the subtle seizure. We will see the subtle seizure. And most common cause of seizure is was asked in your exam, and that is your SHIE, stands for hypoxic ischemic encephalopathy. Now different type of seizures you have to study right here, sir. Absent seizure, how the presentation is going to come. The teacher will be complaining, the school age children is looking up without going unconscious. ऊपर देख रहा आसमान को बिना unconscious हुए. That is going to be the present also. Absent seizure. Drug of choice less than 2 years is going to be the 𝗲𝗵𝗵𝗺, and drug of choice more than 2 years is going to be the valproate. Is going to be what, sir? Your valproate. Generalized tonic-clonic seizure. The drug of again choice is valproate. Febrile seizure because of fever, IV, lorazepam, rectal, diazepam, prophylaxis, clobazam. Again दोबारा से, sir, IV, loraza, rectal, diaza, prophylaxis, clobazam. So this is what you need to remember for the absence, GTCS, and the febrile seizure. Febrile seizure. Sir, neural tube defect. What is the most sensitive marker, most specific marker? If you see the most specific, that is your choline esterase. Again, exam question. Most sensitive, if we talk about, sir, that is alpha-fetoprotein, sir. And prevention is done with the help of folic acid. Can you tell me the dose of folic acid? Folic acid, sir. Folic acid normally we give 500 mcg. If neural tube defect is already there in the, to prevent it, if already the child has bond with that, how much we will give? In that scenario, 4000 mcg. 4000 mcg, 4 gram. बिल्कुल सही बात है, अर्चित. Now, sir, different type of neural tube defects we were talking about. Most specific was acetylcholine esterase, and most sensitive is going to be the alpha-fetoprotein. Alpha-fetoprotein. My dear friends, spina bifida occulta, meningeocele and myelomeningeocele. What are they? You will see right here. The hair and the skin is covering the defect right here. So this is spina bifida occulta. Sir, if your meninges are coming outside, this is meningeocele. And if along with the meninges, if nerve fibers are also coming outside, this is called as myelomeningeocele. Skin और hair ने defect को cover करा तो spina bifida occulta. और अगर आपकी meninges बाहर आई तो meningeocele. और अगर meninges के साथ nerve fiber भी बाहर आए, that is called as myelomeningeocele. That is called as myelomeningeocele, sir. Sir, if brain is absent, yes, brain is absent, this is called as anencephaly. And sir, if brain is herniating out, this is called as encephalocele. This is called as encephalocele. Encephalocele. Then cranioschisis, racheschisis we'll see, where brain plus spinal cord is absent, upper part. If lower part is absent, we will call that as racheschisis. Racheschisis. So these are some neurological defects you have to remember for the exam. My dear friend, next is dehydration. The most common cause in Indian dehydration is diarrhea, and most common cause of diarrhea is rotavirus in the children, and in the adult, or you can say after the virus, the cause is E. coli. The cause is E. coli. Now mild to moderate and severe dehydration. What will happen in that, sir? In the mild to moderate, the child is thirsty. In the severe, the child is drowsy, not expecting to have a water. अगर पानी मांग रहा है पीने को तो mild to moderate, पानी नहीं पी पा रहा, that is going to be the severe dehydration. Sunken eyes can be seen in both. Skin pinch time can be delayed in both. But main is thirsty. Main is thirsty. Now ORS, yesterday also we talk about the sodium and glucose is 75, potassium is like a kela 20, citrate is like a santra 10, बचा हुआ chloride is 65. Now coming to the treatment of severe dehydration, and the fluid of choice for severe dehydration is Ringer lactate IV. Sir, how much we give? For the first 10 kg, it is 100 ml per kg. For the next 10 kg, it is going to be the 50 ml per kg. 50 ml. Can you tell me for the 15 kg child, how much ml fluid you are going to give? How much ml fluid you are going to give for the 15 kg child, sir? Yes, it is your 15 kg. This is going to be your 1250. अरे पहले 10 किलो के लिए 1000 हो गया, अगले 5 किलो के लिए 50 mg के हिसाब से 250 हो गया, 1250 हो गया ना. Now age matters. less than 1 year we will take more time, and more than 1 year will take less time. And it is divided into first 30% and 70%, sir. Sir, remember right here, if age is less than 1 year, the first 30% is given in first hour, remaining is given in 5 hours. And half time will be taken for the age more than 1 year. The first 30% of the value will be given in half an hour, and the rest of the 70% of the value is given in remaining 2.5 hours. Remaining 2.5 hours, 3 hours and 6 hours. 3 hours and 6 hours. Why? Well, let's talk about CVS now, sir. Half of it we have covered already in the radiology part, sir. Now, fetal circulation. The important things, one-liners we have to rectify for exam is that blood supply is by 2 umbilical arteries and 1 umbilical vein. Which umbilical vein is left? Left one is left and right one is obliterated. This umbilical artery is carrying deoxygenated blood and vein is carrying oxygenated blood. Done, sir? Now coming to the ductus venosus. Ductus venosus. Ductus venosus किसको दे रही है, sir? Remember right here, sir. Left umbilical vein into the inferior vena cava. Left umbilical vein which is left to the inferior vena cava. Ductus venosus. Now ductus arteriosus. Pulmonary artery to the aorta. Foramen and ovale, sir. Right atria to the left atria. Right atria to the left atria, sir. Right to the left atria, sir. Chali, congenital heart disease we have divided into cyanotic and acyanotic. Sir, acyanotic, the blood is from left side to right side. Left side से right side की तरफ आ रहा है acyanotic में, ठीक है साहब? और cyanotic के अंदर the blood is going from right side to the left side. Right side to the left side. तो right side में अगर हमारा deoxygenated blood है, it will go to left side, there will be a cyanosis. So, cyanosis is seen with the left shunt, and acyanotic pink color may be seen with the right shunt. So my dear friends, this acyanotic are 3D diseases. What are 3D? ASD, VSD and PDA. VSD and PDA. Atrial septal defect, ventricular septal defect and patent ductus arteriosus. My dear friends, what type of murmur you are going to see in this? Sir, ASD तोड़ देता है कौन? MSD, महेंद्र सिंह धोनी. ASD तोड़ देता है, छक्के मार मत याद, मिड सिस्टोलिक. बड़ा ही VSD सब्जेक्ट है, वेरी स्ट्रेसफुल डिजास्टरस सब्जेक्ट, दैट इज योर PSM, पैनसिस्टोलिक मर्मर. दैट इज व्हाट सर? योर पैनसिस्टोलिक मर्मर. एंड PDA इज पढ़ते रहो कैसे? कॉन्टिन्यूअस मर्मर. तो 3 मर्मर्स इन 3 acyanotic disease: ASD, VSD, PDA. ASD is mid-systolic and diastolic. VSD is pan-systolic murmur and PDA is continuous murmur. Then coming to the cyanotic, blue, 5 T's and 2 E's. Then sir, tetralogy of Fallot, transposition of great arteries. The tetralogy of Fallot में कौन सी appearance देखने मिलेगी? Can you tell me which appearance you are going to see in the tetralogy of Fallot? Yes, which appearance you are going to see in the tetralogy? Boot shape. TGA में कौन सी appearance देखने मिलेगी? TGA you are going to see agon string. अब TAPVR, tetralogy of Fallot, TGA, then it is coming to be the tricuspid atresia and truncus arteriosus. Then 2 E's are there. Epstein anomaly. Which appearance you are going to see in that Epstein anomaly, sir? Epstein anomaly you are going to see box shape, abnormal enlargement in the ventricle, left more than right. Then Eisenmenger phenomena is abnormal blood flow. So these are the cyanotic and acyanotic heart disease. Cyanotic and acyanotic heart disease. Now I'll ask you the question which is cyanotic, which is acyanotic. My question number 1 is ASD, VSD and PDA. They are cyanotic or acyanotic heart disease. 2 names in the cyanotic heart disease. TGA, TAPVR, very good. Truncus arteriosus, tricuspid atresia, very, very good, sir. Now, sir, congenital heart disease is diagnosed with the help of a NADA's criteria. So, NADA is having major criteria, NADA is having minor criteria. Sir, major criteria says what? This is again exam question, that is why very important to teach you. Sir, NADA says what? NADA major says there is a systolic murmur grade 3 or more, plus diastolic murmur, plus cyanosis and congestive heart failure. Systolic murmur grade 3 से ऊपर, diastolic murmur, then there is going to be cyanosis along with the congestive heart failure. This is NADA's major criteria to diagnose the congestive heart failure, congenital heart disease. Then, sir, minor criteria says systemic murmur less than grade 3, abnormal second heart sound, abnormal ECG, abnormal chest X-ray and abnormal BP. These all are coming under the NADA's minor criteria. Now my question is, sir, abnormal second heart sound is major criteria or minus criteria? Abnormal chest X-ray, abnormal ECG, second heart sound, systolic murmur, grade 3 से कम, these are part of, this is NADA's minor criteria. अभी तो पढ़ाया तुम्हें. Abnormal second heart sound, ECG, X-ray, these are minor criteria. NADA's minor criteria. Now neonatology is the next topic we are going to talk about. So neonatology, the weight of baby. Remember, the weight at the birth is 2.8 to 3 kgs. 2.8 to 3 kgs. And low birth baby is less than 2.5 kgs. Very low birth weight is less than 1.5 kgs. Very low birth weight is less than 1.5 kgs. Then sir, head circumference is 35 centimeters. And at the time of birth, your head circumference is greater than chest circumference. But after 1 year, what happens? Your chest circumference is greater than the head circumference. And your head circumference, which was 35 centimeter, if it increases by 2 centimeter and become 37, 38, 39, anything, that will be considered as hydrocephalus. Sir, can you tell me hydropneumocephalus, which sign is seen? I taught you in radiology. Can you tell me which sign I am talking about? Which sign you are going to see in the hydropneumocephalus? The mountain was there. This is the biggest hint I can give you all. Some mountain sign was there, sir. That is Mount Fuji sign. Now, sir, the question is, newborn do not shiver and do not sweat. So how it generates heat? So heat is generated by another famous MCQ, that is by lipolysis of the brown fat. Yes, that is by lipolysis of the brown fats, my dear friends, which is present at mostly nape of the neck, my dear friends. Then, sir, then there will be a hypothermia less than 36.5 degrees Celsius. We call that as hypothermia, and more than 37.5 degrees Celsius called as hyperthermia. The newborn loses heat. How newborn loses it? Conduction, convection, and your radiation. Now what is this conduction? Contact with cold surface. जैसे ही ठंडी जगह को छुआ वैसे ही heat loss हुआ. That is called as conduction. कन्वेक्शन क्या होता है? सोर्स ऑफ कूल एयर. ठंडी जगह को छुआ नहीं पर उसके पास खड़े हो तो ठंडी हवा से आपका जो है काम खराब हो रहा है, आपकी हीट जा रही है बाहर. इवेपोरेशन इज लॉस्ट थ्रू द स्किन. ऑल द टाइम इट विल गो लॉस्ट थ्रू द स्किन, एंड मोस्ट कॉमन टाइम एट द रेट ऑफ बर्थ. रेडिएशन, जो स्किन एक्सपोज होगी उसी से जाएगा. रेडिएशन इज नॉट इन टच विद द कोल्ड सरफेस. कोल्ड सरफेस के पास ही, नियर बट नॉट इन टच विद द कोल्ड सरफेस. कोल्ड सरफेस के पास है बट टच नहीं किया है तो रेडिएशन, विच इज ओवरऑल मोस्ट कॉमन. तो आसपास ठंडी चीजें रहती हैं जिसकी वजह से आपका हीट लॉस हर टाइम होता है. एक्सपोज एरिया से इवेपोरेशन मोस्ट कॉमन टाइप एट द बर्थ. देन कन्वेक्शन इज ठंडी हवा छूती है उसकी वजह से. कंडक्शन इज कॉन्टैक्ट विद द कोल्ड सरफेस. दीज आर द डिफरेंट वेज बाय विच एग्जामिनर कैन आस्क यू all of these are following are the ways of heat loss, except so he can give you what's a lipolysis of the brown fat also. That is exclusion, that because that is a generation of heat and this is a losing of the heat, my dear friends. Now coming to another PSM question, लिकू लेबर रूम की क्वालिटी इंप्रूव कर रहे थे. निकू की भी क्वालिटी इंप्रूव करने के लिए गवर्नमेंट ने फैसिलिटीज दी. तो निकू का जो टेम्परेचर है विच इज वेरी इंपॉर्टेंट, नियोनेटल आईसीयू. सर निकू टेम्परेचर इज 25 to 28 degrees Celsius. 25 to 28 degrees Celsius. It should be little bit warm only. Okay. Then coming to the kangaroo mother care, sir. Important topic again. Kangaroo mother care. Indication to start less than 37 weeks or weight less than 2.5 kg. या तो बच्चे का वजन less than 37 week होगा या तो weight less than 2.5 kg होगा. When to stop? How to do it? Stopping is weight more than 2.5 kg हो जाए या फिर the age of the baby should be more than 37 weeks. And how it is given? Skin to skin contact to the baby is given so that mother heat can be given to the newborn baby. Now sequence of puberty in girls and boys. What is first coming then boys? Sir remember, girls के अंदर the first coming is थिलार, that is increase in breast bud size. Last is menarche. Boys, first is testicular growth, and last is beard or sperm arc. Beard or sperm arc. Best method for the growth assessment in child. कैसे पता चलेगा बच्चा अच्छे से grow कर रहा है कि नहीं? So remember, weight for height. Weight for height. How the weight increases? In the first 5 month weight doubles, 1 year triples, 2 year it become 4 times. Very easy, sir. Again, 2.8 to 3 kgs. Sir, in the 5 month it doubles, 1 year it triples, 2 years it become 4 times. So when your weight is becoming 4 times, it is in the 2 years. When your weight is becoming 3 times, 1 year. When your weight is becoming double, that is your 5 month. That is your 5 month. Done. Then coming to the length. At birth the length is 50 centimeter. कल forensic में भी पढ़ाया था सर. Rule of 𝗲𝗵 पढ़ा था हमने. जैसे 2 to the 4, 3 3 the 9, फिर 5 7 the 35, 8 5 the 40, 10 month में क्या होता है 50 centimeter. Sir, 3 month, 9 month and 1 year is important. Firstly, height increases by 10 centimeter, 10 centimeter, 10 centimeter, 10 centimeter. 9 month it will become 70. After 1 year it will become 75. 2 years it will become 90, and after 4 years it will become double. This again is MCQ. When your height is becoming double, so remember after 4 years. When your weight is becoming double, after 5 months. Chali, done. Now coming to the mid-arm circumference. So there is a test called as Bengal test. Mid-arm circumference, we are having a Bengal test. चूड़ियां पहनाते हैं. Then 𝗖𝗵_𝗶 is there. Arnold classification. 𝗖𝗵_𝗶. Remember, normal. The 3 colors are there: red, yellow and green. So normally more than 12.5, then between 11.5 to 12.5, then this is less than 11.5, then this is less than 11.5. Done, sir? So this is a ranging of a mid circumference, and degree grading we are red, green and yellow color. Important, asked in the exam previously, sir. Now malnutrition. Malnutrition, sir, based on the duration and based on the severity. Sir, duration में acute and chronic. Acute में the weight is reduced, chronic में height is affected. When the weight is affected is called as wasting. And wasting, how to check? Weight for height. Weight for height. And when height is affected, that is called as stunting. That is height for age. Height for age. So what is stunting? Height for age. Wasting is W for W. That is weight for height. Then based on severity, we are having severe malnutrition. So what is severe malnutrition? Bilateral pedal edema, symmetrical. First, weight for height less than 3 standard deviation, and height for age. Weight for height is what, sir? Wasting. And height for age is stunting. So wasting, stunting along with the bilateral pedal edema will suggest you of a severe malnutrition. Asked question in your exam. Again, the important topic for next is going to be the 𝗲𝗵_𝗶 versus marasmus. 𝗲𝗵_𝗶 versus marasmus. The protein deficiency, predominant deficiency in 𝗲𝗵_𝗶 is going to be the protein, and marasmus there is going to be the calories. Onset age is 1 to 4 year ka baby. Marasmus is less than 1 year, sir. Sir, edema is present in 𝗲𝗵_𝗶. 𝗲𝗵_𝗶 ka bachcha is going to have a pot belly, and marasmus bachcha is going to be very thin, sir. Sir, because of a swelling in case of a 𝗲𝗵_𝗶, the muscle wasting is hidden, and because of no swelling in the marasmus, there is going to be the visible muscle wasting. If we talk about the appetite, despite having big belly, appetite is poor, and despite having thin, the appetite is good. When the pot belly is there, the person will be lethargic, and when the pot belly is not there, the person will be alert. Also in the 𝗲𝗵_𝗶, in the hairs, you are going to see the flag sign, my dear friends. Flag sign, my dear. Now this is a 𝗲𝗵_𝗶 baby, and this is a marasmus baby. Now some questions I am going to ask you. Please let me know, sir. Sir, predominant deficiency in the 𝗲𝗵_𝗶 is going to be protein. Very good. Sir, 𝗲𝗵_𝗶 के अंदर what will happen to the appetite? Poor. Which baby is very alert baby, sir? Marasmus. Muscle wasting is hidden in. It is 𝗲𝗵_𝗶. Flag sign is a feature of, this is flag sign. This question can come in exam. This flag sign is a feature of 𝗲𝗵_𝗶. Let's talk about the nutrition. Breastfeeding, when you should start as soon as possible. Exclusive breastfeeding should be absolutely for at least 6 months. Then coming to the prolactin reflex is production of the milk, that is called as 𝗲𝗵𝗿𝗺, and oxytocin reflex is ejection of milk by galactokinesis. These two are very important. Sir. Now cow versus human milk, if we say, sir, cow milk is having a protein called as casein and human milk is having a protein called as whey protein. Carbs are more in human milk. It is less in cow milk. Proteins are more in cow milk, less in human milk. Fat is approximately same. Now storage of breast milk is important. In the room temperature, you can store it up to 6 to 8 hours. In the refrigerator, it is 24 hours. In the freezer with the -20°, you can save up to 3 months. Now short stature, let's talk about the short stature, sir. Short stature. My dear friends, yes, come back. Physiological and pathological we have divided into. Physiological is familial and constitutional. Overall, most common is going to be the constitutional. My dear friends, here you have to remember something. So final height and puberty we have to compare. If final height is short and puberty was on time, this is familial delay. Again, I want to say, final height was short despite puberty on time, this is familial delay. Final height is normal despite puberty was delayed is called as constitutional delay. It's called as constitutional delay, sir. Other than that, pathological means stunting, Turner syndrome, Down syndrome. Now we divide this into two, disproportionate and proportionate. What is disproportionate? Where upper segment, lower segment ratio is abnormal for the age, and proportionate means upper segment, lower segment ratio is normal. Now upper segment, lower segment ratio where it is abnormal, so there is a chances in half of the cases when upper segment is larger and there is a chances when lower segment is larger. So when upper segment ratio is larger, my dear friends, there is going to be the short limb. And lower segment, we are having short trunk. So what conditions we are having with the short limbs, but the trunk is normal? Achondroplasia. Can you give me the input about the achondroplasia? What sign you are going to see on the X-ray pelvis, sir? X-ray pelvis, which sign you are going to see? Then rickets and congenital hypothyroidism. These are for the disproportionate of upper segment greater than the lower segment, then lower segment greater than the upper segment. There will be a problem in the vertebra. So there can be a TB. In TB, you are going to see the port spine. Port spine vertebra. Vertebral abnormalities like kyphosis, lordosis, these kind of things can there. And a fusion of spine can, ankylosing spondylitis can happen. Then there will be a spondyloepiphyseal dysplasia. Spondyloepiphyseal dysplasia. So this is upper proportionate and lower proportionate. Done. Overall, most common type of short stature is constitutional. Most common pathological is malnutrition. And upper segment, lower segment ratio at the time of birth is 1.7:1. After 2 years, it will become 1.5:1. And after 7 to 10 years, it will become 1:1. 1:1. Done. Sir, fetus pass urine by first 24 hours. And fetus pass meconium by 24 to 48 hours. 24 to 48 hours. 48 hours. Now, primitive neonatal reflexes which are present by birth, but they disappear after the birth. Now, rootling reflex, where the baby will be going to the area where you are touching the baby like this. Then there will be a sucking reflex. Moment you are giving something to baby, baby starts sucking. Then there will be Mouros reflex, in which the hand and the mouth will be like this. Then one more reflex is there which is not primitive reflex. It comes after 7 to 10 months after the birth, and that is called as parachute reflex, जिसमें आपके हाथ और पैर दोनों उड़ जाते हैं. That is not a primitive reflex. That is a reflex coming after the birth, and it stays throughout the life. Then parachute reflex, what we were talking about, sir. Done. Apgar score, sir. Apgar score. Apgar. A for appearance. If baby is pink, give 2 marks. If the baby is acrocyanosis, sir, हाथ और पैर क्या है नीले और body pink, give 1 marks. Fully blue baby cyanos, give 1 mark. ठीक है? Sorry, 0 marks. 0, 1 and 2. Now, sir, pulse more than 100, 2 marks. Less than 100 going to be the 1 marks. No pulse, 0 marks. Grimace, cries and pull. You are putting a nasogastric tube and the baby is crying and trying to pull away. 2 marks. Weak cry, 1 marks. No reaction to that, going to be the 0 marks. Activity, full flexion extension is there, 2 marks. Weak flexion is there, 1 marks. No activity, 0 marks. Respiratory efforts, sir, strong cry is there, then give 2 marks. If weak sounds are there, 1 marks. No sound approximately, remember this is going to be the no breathing, 0 marks you are going to give. Can you calculate Apgar score for me? Right here, sir. Sir, baby is pink. Heart rate is 120. Sir, weak response to nasogastric tube, weak flexion, strong cry. चलो फटाफट कैलकुलेट करो फटाफट. Strong cry, weak flexion, weak response to NG tube. जल्दी से. Baby is pink, फटाफट 2 नंबर. हार्ट रेट 100 से ऊपर है 2 नंबर. वीक ट्यूब रिस्पॉन्स है 1 नंबर. वीक फ्लेक्शन है 1 नंबर. स्ट्रॉन्ग क्राई 2 नंबर. 2 4 6 8. करेक्ट आंसर इज 8. दिस इज हाउ यू आर गोइंग टू कैलकुलेट. चलो सर, नाउ लेट्स टॉक अबाउट. एंड मोर देन 7 इज नॉर्मल बेबी. मोर देन 7 इज व्हाट सर? नॉर्मल बेबी. नॉर्मल बेबी. नाउ सर प्री टर्म वी टर्म छोड़ो, आओ जेनेटिक डिसऑर्डर की तरफ. लेट्स टॉक अबाउट द नेक्स्ट टॉपिक and that is what sir? Your genetic disorder. So number one thing we are going to discuss here is a trisomy 21. Trisomy 21. Most common genetic cause of low IQ is trisomy 21. What special features you are going to see, sir? Abnormal ears, sir, flat nose, flat face, 𝗖𝗵𝗵𝗶𝗵, plus which congenital heart disease is associated with? This is endocardial Cushing defect. Endocardial Cushing defect is a most common congenital heart disease associated with the Down syndrome, which is itself a most common genetic cause of low IQ. Trisomy 21. Edward syndrome. E for Edward, E for election. Election कौन से उसमें डालते हो? ताल में 18. Trisomy 18. Short neck, overlapping of the fingers, club foot. Overlapping of the finger, club foot. Club foot. Club foot होगा तो which splint you are going to give? Can you tell me which splint you are going to give, sir? Dennis Brown splint. Dennis Brown. Congenital 𝗵𝗵𝗵𝗵 equinovarus सुना था ना? और टाउ प्यूबर्टी कब आती है? 13 years में. So what is going to happen? Cleft lip, cleft palate, polydactyly. Cleft lip, cleft palate and polydactyly, my dear friends. Turner syndrome, 45XO. Sir, this is seen in the females with the normal IQ. 45XO. What is going to happen? There is going to be the webbed neck. There is going to be the broad spread nipples. These are shield chest. Abnormal mensuration with the normal IQ. This will suggest you of a Turner syndrome. This will suggest you of a Turner syndrome. Noonan syndrome, pseudo-Turner. Can be in the male, can be in the female, and IQ is less. Rest features like undistended testes, triangular faces will be there in the Noonan syndrome. Klinefelter syndrome. Klinefelter syndrome is 47XXY. Sir, टांगे लंबी लंबी, long leg, hair absent, axillary and pubic hair. Axillary pubic hair बिल्कुल absent. Small testes, small penis. Puberty starts at time but progress slow. लंबी टांगे, गोरा चिकना बदन, लंबी height, that is Klinefelter. And under small testes and small penis is hidden gift. That is Klinefelter syndrome. Klinefelter syndrome, sir. Then coming Angelman syndrome. Angel's man is having low IQ because angel is making the man fool. So low IQ, smiling face, and also getting seizures. Chromosome defect on 15q chromosome. 15q chromosome. 15q chromosome, sir. I ask all these 7 chromosomal abnormalities and you guys guess it because one is going to be your exam question, and next we are going to talk about the milestone, my dear friends. My dear friends, number 1 is, sir, most common cause of genetic cause of low IQ. Most common genetic cause of low IQ is going to be Down syndrome. Can you tell me the trisomy in the Down syndrome? 21. Very good. Sir, long leg, absent axillary pubic area hairs. Along with that, there will be a short penis and testis, small penis and testis. This is going to be the Klinefelter syndrome. Klinefelter syndrome. Sir, cleft lip, cleft palate, along with the polydactyly. We are talking about, sir, undistended testis, triangular faces, low IQ, shield chest, webbed neck is a feature of Noonan. Coffee with scrub, very good. It's Noonan. Pseudo Turner. Sir, a female with the normal IQ having broad spread nipple and a webbed neck. Now your diagnosis, and that is Turner syndrome. That is going to be the Turner syndrome. Let's move on to the next topic called as milestone. Now sir, milestone, language milestone. सबसे पहले मोनोसिलेबस. मोनोसिलेबस क्या होता है? मा, बा. 9 मंथ में क्या बोलता है? बाई सिलेबस. मामा, बाबा, बाबू. 1 ईयर में बोलता है 2 से 3 वर्ड. आई लव यू. 2 साल में क्या बोलता है? पूरी कहानी, सॉरी सेंटेंस बोलता है. आई लव यू फ्रॉम डे 1 ऑफ कॉलेज. देन 4 साल के बाद पूरी कहानी. I love you from moon and back, this, that, we went there, we did this, that, I can't live without you, this. So this is storytelling. The storytelling is 4 years. Sentence is 2 years. 2 to 3 words is 1 year. Bisyllabus is 9 months. Single syllabus is your 6 month. Done and dusted. Social milestone. Social smile. It comes in 1.5 month. Can we take that as 6 weeks? Yes, S for 6, X for smile, S for smile. Recognize mother, माता जी को पहचानता है 3 महीने में. ठीक है साहब. Then mirror smile 6 month, social smile 6 weeks, mirror smile 6 month. बाय बाय, मम्मा के यूट्रस को कब बाय बोलते हो? 9 महीने में. तो बच्चा बाय बाय करना भी कब शुरू करता है? 9 महीने. 9 महीने में जो दिखा, चाची दिखी बाय, मौसी दिखी बाय, मामू दिखा बाय, अंकल दिखा बाय, मोहल्ले वाले बाय, गांव वाले बाय, शहर वाले बाय, इंडिया वाले बाय, रशिया वाले हाय. चलो डन. सो दिस इज बाय बाय इज 9 मंथ. बाय बाय इज व्हाट सर? 9 मंथ. ठीक है. चलो पीका बो गेम. ठीक है, पीका बो गेम 10 to 12 मंथ. मोची छुप गई, मोची आ गई. दिस इज कॉल्ड एज पीका बो गेम. 10 से 12 महीने में खेलने लग जाता है. स्ट्रेंजर कहाँ रहता है सर? 7 समंदर पार. तो 7 मंथ. एंजाइटी क्या है? 7 मंथ. स्ट्रेंजर. सेपरेशन सर 14th डे ऑफ February इज व्हाट सर? योर वैलेंटाइन डे. और वैलेंटाइन डे वाले दिन क्या होता है? प्यार होता है. चलो याद रखिएगा, सेपरेशन एंजाइटी इज 15 month, is 15 month. सर कलर जेंडर नेम इज 3 year. देन कपड़े खोलना कब शुरू करता है बच्चा? 2 साल में. पहनने कब लग जाता है? 3 साल में. बाएं हाथ से कि दाएं हाथ से लिखेगा? दैट इज 4. बावल कंट्रोल पहले आता है 4 साल में. ब्लैडर कंट्रोल इज कमिंग एट 5. इज कमिंग एट 5 years सर. देन कमिंग टू द फाइन मोटर माइलस्टोन सर. बाइडेक्स्ट्रस अप्रोच 4 month. ट्रांसफर करना शुरू करेगा चीज़ों को. ऐसे मैंने कब पकड़ लिया, इधर से इधर ट्रांसफर 5 month. एक हाथ से पकड़ना शुरू करूंगा 6 मंथ. अल्नर ग्रास 7 एंड रेडियल ग्रास 8. इमेच्योर पिंसर ग्रास 9 एंड मेच्योर पिंसर ग्रास एट 12 month. एट 12 month. देन सर कप विदाउट स्पिल एट 15 एंड स्पून विदाउट स्पिल एट 18 month. लाइन कब ड्रॉ करेगा? 2 साल में. सर्कल 3 साल में. स्क्वायर या प्लस 4 में. एंड ट्राइंगल 5 में. हेक्सागन 6 साल में. हेक्सागन 6 साल में. Then gross motor milestone, my dear friends. Gross motor milestone. Support and without support. If a baby is sitting with the support, this is 5 month. And without support is 8 month. Standing with support, 9 is looking like a stick and we are taking the advantage of stick right here. Stand with support is 9 month. Without support, 12 month is also 1 year. It is 1 year. Walking is 12 month to 13 month. And walk without support is 13 to 15. Running is 18 month. Climbing, jumping is 2. Climbing, jump and climb stair 2. Skipping, climbing and jumping stair with hand. 2 साल में हाथों से चढ़ने लग जाता है. 4 साल में skipping and jumping floor on the individual foot. Now some questions and then we are moving on to the next subject called as obs and gynae. So my dear friends, let me ask you some question from the motor milestone. सर बाय बाय कब बोला बच्चे ने? सेपरेशन एंजाइटी. Recognize mother. 3 months. Very good. Sir. Mature pincer. 12 months. Very nice. Sir. Stand without support. Stand without support. Peek bow game. Peek-a-bow game.